I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist. In this video, we're going to be talking about inpatient pediatric community-acquired pneumonia. Causes of community-acquired pneumonia are either viral or bacterial. Overall, viruses are the #1 cause in children, especially those 0 to 5 years old. And common viruses include RSV, rhinovirus, as well as influenza. Bacterial causes include Streptococcus pneumoniae, H-flu, which is less common today with routine childhood vaccinations. However, if those decline, you will see more H-flu. Overall, strep pneumoniae is the #1 bacterial cause. Other bacterial causes include atypical pathogens, including Mycoplasma pneumoniae and Chlamydia pneumoniae. These should both be included in your hospital's respiratory pathogen panel, so you can look for them there. Overall, inpatient cases have increased pretty dramatically, especially over the last 5 years. In terms of diagnosis, we of course want to get a chest x-ray. However, this will not help us differentiate bacterial from a viral cap. We also want to get a CBC. Leukocytosis is really common, but you can see leukopenia, so also pretty non-specific. And then we might get a CRP. Again, not specific, but if the patient has severe cap, we can use it to really just trend to see if patient's improving. Procalcitonin, on the other hand, can help us differentiate bacterial from viral cap. So procalcitonin greater than 0.25 has a 96% negative predictive value and 85% sensitivity for community-acquired bacterial cap. So if your procalcitonin is greater than 0.25, definitely start antibiotics. If it's less than 0.25, especially less than 0.1, no antibiotics. We're pretty sure in this case it wouldn't be a bacterial cause, in other words. And then you, of course, want to do a respiratory pathogen panel to see if there are viruses or atypical pathogens present. Sputum cultures are really difficult to obtain, but in intubated patients, they're feasible. So you can get a sputum culture in intubated patients. And then finally is a blood culture. So this has low yield. Only about 2 to 7% of blood cultures will be positive in pediatric cap. So in floor status patients, I wouldn't get a blood culture. It's actually more likely to show you a contaminant than a true pathogen. But in severe cap, patients admitted to the ICU, or patients with white blood cell count less than 4 or greater than 30, or immunocompromised patients, or patients with a complex chronic condition, you should get a blood culture to see if there is a more uncommon pathogen present. Viral cap management is mainly going to be supportive care, so hydration with fluids, oxygen, antipyretics. If the patient has flu, they're indicated for Tamiflu or oseltamivir, which is the generic name. For bacterial cap, we obviously need to treat with antibiotics. So next, let's talk about inpatient bacterial community-acquired pneumonia management. For hospitalized children with community-acquired bacterial pneumonia, empiric antibiotic selection depends on 3 things: vaccination status, disease severity, and concern for atypical or resistant pathogens. Start by assessing pneumococcal and Haemophilus influenzae vaccination status. In fully immunized children with mild to moderate cap, use IV ampicillin or penicillin G. In children who are not fully vaccinated, have severe cap, or are in regions with high penicillin resistance, ceftriaxone is preferred. Ceftriaxone provides more reliable activity against Streptococcus pneumoniae with higher MICs and improved coverage of H-flu compared with penicillins. Most children with penicillin allergy can still receive ceftriaxone. Levofloxacin should be reserved only for patients with a true severe beta-lactam allergy, given its broad spectrum and higher risk of adverse effects. Atypical coverage is not routine. Macrolides should only be added if atypical pathogens cannot be ruled out or are strongly suspected. If used, azithromycin is preferred due to superior tolerability and efficacy. When possible, delay initiation until respiratory pathogen panel results are available, since even a single dose of azithromycin persists in the body for weeks. MRSA coverage is also not routine. Consider adding coverage in children with respiratory failure, septic shock, rapidly progressive disease, necrotizing or cavitary pneumonia, empyema, or influenza. Vancomycin, linezolid, and ceftaroline are all options for MRSA pneumonia. Linezolid and ceftaroline have excellent lung penetration. However, vancomycin is preferred when MRSA bacteremia is suspected, as linezolid and ceftaroline are less reliable for bloodstream infections. Reassess antibiotic therapy at 48 to 72 hours. Most children should show clinical improvement by this time. If there is no improvement, antibiotic coverage should be broadened, such as escalating from ampicillin to ceftriaxone, or adding MRSA or atypical coverage. If cultures identify a pathogen, use susceptibilities to guide therapy. Remember that blood culture contaminants are common, so results should be interpreted carefully rather than automatically narrowing therapy. If the child is improving and tolerating oral intake, transition to oral antibiotics as soon as possible. Early IV to oral transition shortens hospital stay without worsening outcomes, even in severe CAP. For mild to moderate CAP in pediatric floor patients, treat for 5 to 7 days if the child showed appropriate clinical improvement by 48 to 72 hours. Children discharged from the floor within 48 hours may be treated with shorter courses of 3 to 5 days. For severe CAP, treat for 7 to 10 days, with longer courses for slow response or bacteremia. For complicated pneumonia, including empyema, abscess, or necrotizing disease, total duration may extend to 2 to 4 weeks, depending on drainage and clinical course. For CAP prevention, infants are indicated for nirsevimab or Beyfortus for RSV prevention in their first year of life, maybe in their second year of life, depending on their comorbidities. I do have a video on RSV prevention if you want to check that out. And then otherwise, routine childhood vaccines, including pneumococcal, so PCE20, Haemophilus, and then MMR, and varicella. Thank you so much for watching. If you liked this video, please subscribe and let me know in the comments what questions you have and what topic you'd like me to cover next.